you guys. I think that everybody's just about done sharing. So let's just talk about those techniques. So muddiest point. Can someone concisely describe what this is and how they might use it?
That was the part I didn't understand.
One of those ones that you can use for, you know, when we were talking about the learners who seem like they know everything. I think that this is one of this one and harvesting, and actually thinking hats too, I like to use in the learners that already think they know everything. Because there's always something that they're still confused about. Okay, so next one, harvesting.
So what is it that you're seeing here, and what could this be? And almost like the summarizing and the snaps, and pulling it together, and then taking the next step of say, okay, so given that the child is, retracting and grunting, and what would your next, how would you look at it next? It's pulling everything together.
Perfect. And then moving on to thinking hats. You guys had a great conversation over here about how that might be useful.
Oh, we were talking about sort of like evaporating the tunnel vision of this is your patient, this is their disease, this is the treatment we're going to give, and instead expanding to say like, well, how are those otherwise involved with the patient going to be affected? How is nursing going to be affected? What do they have to deal with that you're shouting out to them? How is respiratory going to be involved? And then even more broadly, how are the patients' other facets, their family members? Do they know what's going on? Are they on board with the plan? Have they already had this conversation without you?
That's a great summary. So that one in particular, I think, can be really helpful when you have that like second-year resident who feels like they've mastered some, some area, and you're trying to kind of push them to the next level of thinking about it beyond that, their little narrow view of it. And then finally, fishbowl. How about this one?
Makes them not feel inadequate when you're asking what you think to be a second-year level question, and then they don't know the answer. And so it's just a way to convey information from the most basic to the most complex. And then when you get all the way to the top and everyone's answered all the questions, then you can talk about some of the finer nuances of whatever that teaching point may be.
That's a great summary. I think it's a really nice way to build a learning community. We so often are working one-on-one with residents in our environment, but not necessarily with the group of them together. So when you do have the time and you're in the work area, just grabbing a few of them and doing this. Yes, sir.
There's an adjustment to fishbowl that I use sometimes if I'm concerned that there may be some confidence issues amongst the people that are there. Or if you start it and you sense that people's minds are going blank, or they're making an excuse to kind of leave the room so they don't do you know what I'm talking about? Okay. What, I gotta go, I think a family member just came in, I gotta go, okay. All right, so a way to kind of make it a little bit safer for the folks involved is you can have them, instead of asking them kind of different level questions, you can have them teach different level concepts. Right, so the med student teaches like something they know about that, and then the intern teaches something they know about that, and the 2 and the 3 and 4, and that way they have everybody learns something, but it's not quite as uncomfortable as fishbowl. It can sometimes be great, sometimes go sideways. So.
I think that's a nice take on it. Speaking of medical students teaching, back to the jigsaw. I know earlier somebody alluded to that one difficult learner case we had where everybody was being mean to them too because they didn't want them there. I know that we all work in busy environments, and sometimes it can be challenging when you do have a lot of learners trying to figure out how to engage them all. One thing that I'll do if I have a lot of learners, especially junior learners, and I don't have time to supervise an actual patient over and over and over again, if there's a topic that comes in, so 2 weeks ago we had a new onset seizure patient come in, and we happened to have 3 medical students, and I assigned each of them a piece of that to kind of read up on for 20 minutes. They taught each other, and then we talked about the management. So somebody did, febrile seizure. Somebody else did the acute management and status epilepticus. Somebody did the workup of a first onset seizure in a pediatric patient. And so that's a nice way to use the jigsaw method actually in the clinical environment too. So on your yellow piece of paper in front of you that was just passed out, we have a few different scenarios, brief scenarios. We'd like you guys just to read them in your small group together, or you can do the big table, and just think about how you might be able to use these techniques we just used to apply them to these brief scenarios. chance to go through all of the scenarios, but you had some very good ideas. And the point of this was to realize that there's not any perfect, there was no right answer. And so as you guys pointed out, you really could use any of the techniques for the scenarios. It really just depends on what your goal is, like what your learners' need are and what your goal is in that teaching point. And the most hilarious thing that came out of it is these guys pointed out that when we were teaching about the number 2 with the metabolic acidosis, that mud piles would be appropriate for Muddy's points. So we've tried a bunch of different quick things: thinking hats, jigsaw, step-up questioning, harvesting, Muddy's point, and fishbowl. And so we just wanted to give you a menu of a few different things that you guys could use. And so just take 30 seconds and just write down anywhere on your handout something that you're going to try on your next teaching shift, and then we'll switch to the next activity. Everybody's got their action plans? It's a good educational concept to make sure your action plans. All right, the next thing that we were going to do was speed dating. And so y'all came here to learn how to teach and to do bedside teaching. And so I thought we ought to at least make you or ask you or request that you practice something. And so what I'm going to do is ask you to take about, I'll do the timer again, about 2 or 3 minutes. Think about something you want to teach. And remember, you've learned all of these different techniques. There's other ones there. There's spit, and there's a whole list of them that we did: SNP and snaps and teaching scripts and horizontal learning. There's all kinds of different methods that you've learned to teach today. So take 1 or 2 minutes and think about something you want to teach, and then I'm going to ask you to teach it. Do you want to teach it to your neighbor who you've talked to, or do you want to teach it to somebody you haven't met? What would you? Somebody you haven't met. Okay, you get 3 minutes. Ben, I'm going to give you a little bit longer. So what you're going to do is you're going to think about something you're going to teach, and then you're going to stand up and find somebody you haven't met before, and you're going to teach them, and then they teach you back. So you'll do an exchange. Is that fun? 3 minutes of teaching, 3 minutes of prep, 3 minutes of teaching, 3 minutes of teaching.
Teaching a case or teaching something that we learned today?
We want you to be teaching. If you're going to go back and teach faculty, do something we teach, whatever you want to do. You're just teaching.
All right, go ahead and switch if you haven't already.
So 6 of you up there, the rest of you don't get to go up. Go. Back to you. Yep. Yeah, you're right. 6. Jason. Okay. I guess now I get to ask really awful questions. All right. This is a ask them your toughest questions session, or your easy questions, softball, whatever you want. So what do you want to know from them in terms of clinical teaching or managing faculty or difficult learners or whatever?
Managing
What do you want to ask them?
All right, I thought this might have been a little taboo to ask because it's a room full of educators, but I'm going to go for it. Are there difficult learners who are unsalvageable, who no matter what you do, and if there are, some nods, if there are, how do you make that determination? At what point do you say, like, this isn't going to work between us? Asking for a friend.
It's not you, it's me.
I'll give that a shot, I think. Hello? Hello, I'll just project. Can you hear me okay? All right, so I think as a program director, I've seen a lot of residents come through. And what you have to do first, if you're trying, kind of the unsalvageable learner comes in, quote unquote, comes in various flavors, right? Some have a personality disorder that it's just there. And no matter what you do, no matter what trick you use, it's there, right? So then what you focus on is trying to give them things they can say and things they can do to be successful in the clinical circumstance, with the goal being making them a successful physician. But sometimes it's because they chose the wrong specialty. Sometimes it's because they're a fish out of water. This chaos that we work in isn't for everybody, and they may be a great physician in another specialty. And so sometimes you have to kind of pull it back a bit and figure out if they are best suited for something else. And that can be a really hard thing as a program director too, right? Because you really want them to be successful, but then you have to kind of meet them where they're at. So those just, I mean, we could talk about this a long time, but those are a couple of important ones.
I think the key I have with that is you don't make a decision that they're uneducatable until you've tried.
Yeah.
So you never make that determination until you've done your work, where you're saying, we're having difficulty, let's work together and figure out how we can make you better. Let's try this technique, it didn't work. Let's try somebody else, maybe you don't work well with me. Let's try another technique. And at some point you go, we've done enough, but then you've done enough. Right? What I find is people go, that person is so hard to teach. Do you think they're hard to teach? You think they're hard to teach, right? They're hard to teach. You had a pain. Yeah, it's trouble for you too. Yeah, it's a horrible learner. And that's not the way to do it,
No.
right? Because then you're making a determination, and then all you're doing is trying to gather data to prove your point. Instead of assuming that everybody can make it, and then figuring it out along the way as you're trying to help them.
I think the other thing to keep in mind is just a little bit of humility on behalf of ourselves. I think recognizing that we are also human, we're not going to be perfect, and we're not going to be able to be successful educators for every one individual, and just being able to reach out to somebody else who might have a different technique is also a good strategy if you've tried some of the other things and just feel like you're not making any headway.
This might be a dinosaur question, but I think objectively with new evidence-based medicine, and many of the residents simply know more about newer medicine than I do. How can, other than learning more, learning to use evidence more, which obviously is one solution, how can I still be of value to a resident who knows the literature and the more recent literature better than I do?
I think often it's more challenging to teach them how to function efficiently in the department than it is to teach them medicine. And it's I would say from a remediation standpoint, it's way more challenging to increase efficiency and learn how to optimize what you do in the department. And that's probably something you can offer even if you feel like you're not up on the latest in the clinical literature. And then I let them educate me through the genius of the people I work with. And the stuff they teach our residents. They teach me about the latest and greatest that I haven't read yet.
So first I thought that question was just directed at me. I thought you were talking to the dinosaur on the, so I don't know why they're answering. One of the things that you have as a dinosaur, like I have as a dinosaur, is that cutting edge is cutting edge for a short period of time, and then often goes back to what we were doing, right? So let's talk about Bell's palsy. Steroids, antivirals, both, neither, steroids. Which one is it now? I have no idea. Because we've been through the entire cycle. So sometimes you being able to say, I'm a bellwether in this, and it will change over time. So understand why we're saying that right now. Understand that this may change in your lifetime is something you can do because you've got a span that you can teach them from. The other thing I do is when they know more than me, like a cardioselective beta blocker, what I was taught was a cardioselective beta blocker, is now considered just a generic beta blocker. And then they were arguing with me, and I was like, okay, help me. Teach me and everybody else what I'm missing. And they loved it. They loved to be able to sit down and teach me what is now considered cardioselective. And I said, they didn't teach me that when I was in school, and it's not something I've read up on. That helps me out a lot.
I was going to say, there's also some value potentially in just helping teach them that like not everything that's cutting edge and that they heard on MRAP is really great. There is a real like tendency from residents to like jump on board with stuff real fast, and you know, to kind of teach them the value of, okay, well, like let's go back to some of the, you know, foundational principles. What would, you know, Rosen say about this? What would, you know, Tintinelli say about this? And, you know, how does this new thing that you're trying to bring in from MRAP or, you know, whatever, MCRIT, you know, how does this jive with the old way of doing things? And is there perhaps a sensible place to meet in the middle that combines new cutting-edge evidence-based medicine, but also, you know, the time-tested approach, I suppose?
I have one more comment on that question.
Can I?
Go ahead.
The other thing I think you have in comparison to one of maybe your senior residents who is good at reading the literature is your experience and your expertise based on 20, 30, I'm not going to assume your age, but a number of years of patient care. Because a lot of the decisions they make are not EBM based, right? It's, does this patient need to be intubated? Does this patient need to be admitted versus discharged? And all of those are, you can use your base of expertise and experience to really teach them a lot.
And I think learners respond well to stories. And so I think being able to provide a lot of different anecdotes from your experience over the years, they will respond very well to.
Study after study on clinical decision rules show that a experienced physician's gestalt beats every single one of them. Okay, so with your residents that are fixated on X study of N number of patients, you have a clinical experience of 10,000 patients that presented with that weren't in that study, but your study is much larger than that study was. So, and this is shown time and again. So I think that is often very, very helpful, because this type 1 thinking and type 2 thinking and blink and gestalt and the sense that, yeah, I know the decision rule tells me to do this, but that's not the right thing in this particular patient at this particular time. And that comes with seeing thousands of patients. And that's been borne out. That's research-based.
I was going to be the next dinosaur, but actually you answered the question. The most common scenario I get is this MRAP being gospel, and I don't always know how to manage that. It seems as if there's this, belief that that is in fact the truth, and anything we could possibly teach them is not the truth. And so those conversations can be hard. So you've already kind of touched on that, and I appreciate that very much.
How do you hit that one straight up? They come in with this new MRAP thing.
You opened the MRAP.
I know. I mean, I think it's important to, engage in the conversation with it, because, it's good that they're doing lifelong learning, and, I'd rather them be doing that than, reading some junky magazine or something. But, I mean, I think it's, the question to them is always, well, did you read that study yourself? Or did you just hear about this on the podcast? What can you tell me about that study? Who was included? And, start asking them some of these tougher questions about, does that apply to this patient that we have in front of us right now? And, put them on the hot seat a little bit, rather than letting them kind of put you on the hot seat. And I think you can at least give them a little bit of a better perspective on it, of okay, if you're going to be trotting out new things, sure, you can do new things and adopt new practices, and that's all well and good, but boy, you better know what you're doing if you're going to be deviating from the quote-unquote way things are done.
I think one of the biggest things that we can teach our learners is really for them to be critical appraisers of what's out there and all the information that is available, because it's amazingly robust and extensive. But we really want them to look at these things with a critical eye and not just take it for, gospel truth based on one person's opinion and one person's perspective and lens of whatever resource that they were referring to.
Right, that's the key, is it's one person's opinion, right? It's whoever writes that blog, so it's whoever wrote the chapter, whoever wrote the article, it's one person's opinion or 5 people's opinion. And I love it when EM Crit and EM Abstracts and all the different podcasts argue over one thing. I absolutely love that. I'm like, so they're right this one time, but they're wrong this time. So it's great to bring it up when they're contradictory. You'll make the point that there is something to gain from listening to EM Rap, but you've got to tell me how you're going to assemble that into all of your other knowledge. And I'll tell you how I put it into my knowledge, whether or not it matters or not.
Other questions?
I think in this table we were talking about earlier about, when the resident comes to you with a presentation that it really is way off from when you go back and you actually assess this patient. Now, I've been educating for years too, but it also creates like a trust issue between what you are really learning from the resident or what you're getting from the resident. How have you dealt with that before? Because I had a couple instances that I have to have people even go into remediation for that because they're so way off, and sometimes it could be cultural, it could be there's so many things. It could be like gaps on knowledge, it could be that they're misreading the situations. How would you normally approach that, and how do you help your faculty to again gain trust on that resident? Because once they get blackballed, doesn't matter how much you try to put in, remediation and everything else, it basically gets out of the grid.
So I think I think you kind of mentioned part of the solution in your question, which is figuring out what the underlying issue is there, right? Is it that they don't know the right questions to ask and they think they need an answer, so they just kind of made one up? Is it that they are trying to be efficient and missing asking questions? What's the etiology of that? Is it that they have a personality disorder and they just lie and you can't fix that, right? But it's having a lot of conversations with the resident.
Not that we've encountered that.
Never. To try and figure out what the underlying etiology is so that you can target your remediation plan towards that. In terms of faculty then not blackballing your resident and always negatively evaluating them afterwards, I think you can get to that with faculty development stuff, right? We're all educators, we all want them to be successful, and so really coming back to your faculty and saying, we're working on X, Y, and Z, we want to make sure that, we want to remind you to evaluate the person that you worked with today, not the person you remember from 3 months ago, because they've been making progress on these issues and we need to know where they are. The other thing I've done is have them go to some of our rotation sites that aren't our home program site and getting feedback from people working with them for a month who don't know them or met them once, and that can give you some objective input as well.
Yeah, I think another useful tool that I've found to try and diagnose a problem is actually just accompanying them on a patient encounter from beginning to end. And you can pick up on a lot of detail that I think oftentimes we miss if we allow them to just go in, kind of do their thing, and then come back and sort of, present to us. I think if you actually follow them and you do basically just a direct observation of their clinical encounter, you'll pick up on a lot of tips.
Another thing that we've used that I think has been successful for these sorts of things, so we had a third-year resident that was just, it was too slow. He needed to focus on, EM-specific workups and not like internal medicine-style workups. And what helped for him, and I think for the faculty group, was to filter out all the noise. So he had personalized feedback cards. So essentially that was the only thing you could really give him feedback on for the shift. Like that was his area for growth, and it helped the faculty to know that like that's what they should be looking for and helping him with and offering him tips on. That it helped him to sort of filter out all the other things of like, because if you let faculty, you know, give whatever feedback they want, like one day it's going to be this and another day it's going to be that. So, you know, really just drilling down once you've got that issue diagnosed and kind of doing the one thing at a time approach was tremendously helpful for him.
I think on that specific shift, what I will do is tell them, you got this story, I got that story. It doesn't mean one's right, one's wrong. And I say, here's the problem. If it's your story, we're going to go this way. If it's my story, we're going to go this way. See that difference? Let's go back in the room together. And then I will ask the questions. I'll say, we've got a little bit different picture, and it's sending us down two different ways. So we're trying to understand, and then I'll ask the question in a non-biased way, and they get the answer back. And I got to tell you, sometimes they were right. Right, which is really frightening. But sometimes I've pushed them in the wrong direction. But then at the end, we get to say, this is what we're chasing. It's really effective, I think, when they realize I got the entirely wrong story and I was chasing the wrong thing, especially when the diagnosis comes out to where you were headed.
All right, one more question. Okay, so then evaluation form.
All right, moment of truth.
Moment of truth. Is it going to work? Everybody pull out their phone. There's no old-fashioned phones, because then we're in trouble.
So, yep, hold your phone camera app up to this, and hopefully it should link you right to an evaluation that you can fill out right on your phone. It is working? Yep. Wonderful. The miracles of modern technology.
Very last thing.
Qualtrics. The speed dating teaching. The quick speed dating.
Oh, next is the speed dating. You all automatically selected to go to a restaurant with
Yeah, we
strangers.
have 4 one-hour dates the rest of this week.